I'm Steve Sarkisian, founder and CEO of Oklahoma Eye Surgeons, and I'm a fellowship-trained glaucoma surgeon and cataract surgeon in Oklahoma City. And this lecture is sustained-release glaucoma medications and compounded glaucoma eye drops. I want to thank the organizers for having me at your excellent meeting. This is my financial disclosure. Of note, I am a consultant for Allergan and Glaukos, as well as OSRX Pharmacy, which is owned by Ocular Science. So why is a lecture about sustained release medications and compounded medications even relevant? Well, here's the question: is how compliant do you think your glaucoma patients really are with their eye drops? If you look at the data for compliance with glaucoma medications, you will see that the compliance rates drop off precipitously especially if you give any patient more than one bottle of medicine. So here you can even see this very old data showing pilocarpine and the significant drop. But look at all the other medications that we typically prescribe for glaucoma all the time. Even after 12 months, only 59% of the patients even that had an opportunity to continue the medicine after it was initiated, and only 10% actually had medication available continuously. If you look at study after study where you evaluate patient noncompliance, up to 90% rate of noncompliance with anti-glaucoma medications, with 50% of patients who stop taking medications at 6 months. Glaucoma medication persistence is indeed very low, regardless of who your patients are. And this is a graph that shows many patients just even stop refilling their medications for their glaucoma drops over time. By 1 year, less than half were still on drops. So why don't patients take their drops? Well, for many, it's cost, side effects. Patients are sometimes just too busy, or they don't have a regular routine. Like people who travel for work, they'll often forget and leave their drops by their bedside. And some people just forget. So think about other eye drop problems that patients have. Sometimes, especially if they have arthritis, the bottles can be too hard for people to squeeze. It's also very common to see patients use more than one drop and they run out of medication before they're able to get their allowable refill. A lot of times patients miss. They'll put in eye drops and it'll land on their cheek. And this is a very common problem. So let's talk about the side effects of these medications. Glaucoma medications and ocular surface disease, really strong correlation. Nearly 60% of medically treated glaucoma patients report ocular surface disease symptoms. And of course, we all know about the irreversible effects of prostaglandins. I really almost never have a patient on a monocular prostaglandin analog because of the permanent periorbital fat atrophy that occurs. And here you see several pictures of patients that have been on monocular prostaglandins where they have enophthalmos in one eye, redness, dark circles under the eye. It's almost like a chemical blepharoplasty, which is most usually undesirable. So there is this odd dynamic of doctors and patients when it comes to medications. Often, we are too busy or embarrassed to have honest conversations with our patients about compliance. And your patient, the patients, they want you, the doctor, to like them. And they want you to think well of them. And they don't want you to think of them as non-compliant or not doing what you say. They don't want to hurt or they just don't want to hurt your feelings or even deal with it, or they're in denial about their own disease, but and don't really think it's all that important. But there are a percentage of patients where they just won't open up, and some just kind of pretend to be taking their eye drops. Some patients, like, they take them the week before the visit, just like some people floss the week before going to the dentist, and they tell themselves that if they kind of come through that visit with a good report and nothing is worse, and their eyes aren't rotting out of their head, then they must be okay, and they got away with it again, and they didn't do any permanent damage necessarily from their non-compliance. So I challenge you, because we know better. We know that the way glaucoma works is non-compliance. People are going blind, and they don't notice it until it's too late. So you really need to keep it real with your patients, and don't let opportunities slip by. Stop thinking you know who is compliant and who isn't, and really confess that you don't know what you don't know. And it's time for us to be creative and to really address this issue. But here's the thing, is that we really need to think of new solutions for this problem. I need to tell you now, the solution isn't to write on the piece of paper or type into the EMR stressed compliance, and then you tell your patient, well, you'll do better next time. We need to really start to identify the patients that are struggling with this issue, and then we need to help them and partner with them to preserve their sight. Enough's enough. We need to stop just stressing compliance and scolding our patients, and we need to intervene. It's time to intervene. So how do you get your patients to fess up about this? Ask open-ended, non-judgmental questions. Keep it light. Put yourself in their shoes. Remind the patient of your partnership in their wellness. Give an example of your own life or a family member when you found it difficult to comply with a regimen. I frequently give the example of my wife, who has dry eye after her LASIK, and I put her on a medicine, cyclosporin, and some tears, and because she had significant eye pain from her dryness, and she got better, and about 6 months later, she was complaining of eye pain again. I said, well, aren't you taking your drops? And she said, well, they felt better after a month, and I stopped taking them. And then it occurred to me that I am not only probably a below-average husband, but perhaps not the best dry eye doctor either, if my own wife didn't understand, based on what I communicated to her, that she needed to take these drops indefinitely. Don't be self-righteous. Don't be like, well, did you take your drops? Well, you got to take your drops. Stop doing that. Stop communicating in that way. Well, you just need to take your drops. If they're struggling with taking their drops, then do something else. Patients who do things only because their doctor says so, they rarely do the things their doctor says. The people that ask the most questions, those are the patients that tend to be the most compliant, because they own their disease. So what's the logical implications of the poor compliance for the contemporary eye surgeon? We need to rethink the glaucoma treatment paradigm. We need to be able to take the responsibility of seeing away from the patients who have to just be taking eye drops every day, or multiple eye drops, and we need to take it upon ourselves to do something about it. So given the data, why do you keep using eye drops as first-line treatment for glaucoma? You need to ask yourself that. It's time we rethink the way we take care of glaucoma patients. So that leads us to discuss sustained-release glaucoma medications, and we have one that's FDA approved, the DURYSTA, which is the sustained-release BIMATOPROST. But I'll discuss also a bit about the IDOSE, which is not yet FDA approved. So an overview of DURYSTA, which is the BIMATOPROST sustained-release implant. It is biodegradable, and it is very small. Here you can see it next to a dime. It's about a millimeter. It's designed to provide slow release of BIMATOPROST, and one 10 microgram implant is similar to a dose in a single drop, of BIMATOPROST dosed daily. Of course, the implant is when it's implanted once, there's a steady rate of release of BIMATOPROST in the sustained release implant ends up being similar to the dose in a single drop given daily. So here's a cool animation of what it looks like, what the inserter looks like. It has a cap, and then it has this tab on the side that allows you to release it. And again, it's preservative-free and solely biodegradable. It targets the delivery to the diseased tissue. It increases uveoscleral outflow, and here you can see an animation of it being injected. Here you go in basically 2 bevel lengths into the eye, stay over the iris. You really want to be definitive and push the button so that it releases the implant. And it needs to be done in a sterile technique. It can be done with an operating microscope or with I mostly do mine at the slit lamp now. There's a cool animation of where it sits in the inferior anterior chamber. And this is an electron microgram showing it with basically it's a polymer matrix implant that is biodegradable into lactic acid and glycolic acid. And then it dissolves over time. Even after a year, you might see some, or 2 years even, you might see some implant present, but it shouldn't have any medicine left in it at that point. And interestingly, you'll see often it won't just stay looking the same. It'll ball up. So DURYSTA works, and we'll look a little bit about some of the Apollo study. Was a study of patients with open-angle glaucoma. But anyone was excluded if they had open aphakic or had an open posterior capsule or had history of glaucoma surgery or extremes in corneal thickness or had poor endothelial cells. But they had to have actual glaucoma, and with a mean deviation loss of greater than a decibel or less than 17 decibels in the implant eye. So what happened was that the patients were washed out of their medication, and then they received the BIMATOPROST implant, the study eye, and once daily BIMATOPROST topically in the fellow eye. And then rescue topical medications were allowed for failure to obtain a target pressure of at least 20% on consecutive visits 1 week apart, or if it was felt by the investigator that it was in the patient's best interest. So a single repeat treatment of the DURYSTA and the study eye was done between day 90 and month 12 if neither eye had received rescue therapy, study eye had failed to maintain a greater than 20% reduction in pressure from baseline, and the initial implant demonstrated adequate safety and didn't contact the corneal endothelium. So the primary outcome was hour-matched IOP change from baseline through 2 years, measured by Goldman, and the data were censored from start of any rescue or retreatment. So what happened? Look, this is really pretty remarkable. If you look at the percent of study eyes that were not rescued or retreated with the BIMATOPROST implant, almost at month 24, 5 of the 21 patients had not discontinued or received rescue treatment in the DURYSTA group. So that means that 23.8% of these patients at 2 years still didn't need any additional treatment. The one BIMATOPROST worked. which really lends itself to thinking that probably what happens there is not that the DURYSTA is still releasing BIMATOPROST, but that there's likely some enduring change to the uveoscleral outflow that occurs in a percentage of these patients where the effect is persistent and lasts. The ocular adverse events that occurred during the 24 months were mostly nonspecific, eye pain and increased lacrimation, conjunctival hemorrhage. Most of these issues were really mostly related to the fact that they had an injection. And that's really why there were more AEs in the study group that got the injection. And they were mostly conjunctival hyperemia, which got better, foreign body sensation, eye pain, all that, conjunctival hemorrhage. And most of these AEs occurred within 2 days after the injection procedure or were transient. And in fact, after 2 days, the rate of hyperemia was more common in the topical group, which one would expect because the hyperemia is a local phenomenon because of the eye drop itself. There were no serious adverse events in any of this. So basically at week 16, it was basically the same pressure as with topical, a single implant controlled IOP up to 16 weeks in 91% of patients, 6 months in 71% of patients, and it was well tolerated, and most AEs were transient. So for the Artemis study, which compared BIMATOPROST, sustained release, DURYSTA versus timolol, and this was a study that really just was IOP change from baseline at week 12. Because it was a drug study, there had to be studies that happened at the same time. In study 1, the DURYSTA group showed a 33% drop in IOP. Study 2, it showed a 32% drop in IOP, so a very significant drop in IOP in the DURYSTA groups. And of course, the most common adverse reaction observed in the two studies was conjunctival hyperemia, as discussed before, but this improved with time. However, it should be noted that in the study group in which there were a fixed dosing of DURYSTA, where patients had up to 3 administrations of DURYSTA in a short period of time. Up to 5% of those patients did have some endothelial cell loss, but when patients only received one DURYSTA during after 12 weeks, really none of them had any significant endothelial cell loss. Unfortunately, the FDA has approved the labeling for DURYSTA as only one injection. Unfortunately, fortunately, we don't work for the FDA. We're trying to take care of patients, and if you are to do an injection, an off-label injection of a second DURYSTA, you have a license to practice medicine, and the patient, if understands that loss of optic nerve tissue from glaucoma is permanent, and not to be cavalier with the corneal endothelium. If there are alternatives to patients at risk, you need to take them. But endothelial cells can be replaced. Optic nerve tissue cannot. And with anything, informed consent is imperative. If you're going to consider doing a second DURYSTA, I have many patients on whom I've had to do a second DURYSTA 6, 9, 12 months after the first one because there simply were no other alternatives to keep them seeing besides major incisional surgery. And I promise you there is a greater risk of cell loss with doing a tube shunt or a trabeculectomy than with implanting DURYSTA. And then finally, the Athena study, which is ongoing, I'm part of this study, is going to be comparing DURYSTA to SLT, and where one eye gets DURYSTA, the other eye gets SLT. It's a randomized, masked study, 2 studies that are ongoing, and this is really important because, in my hands before DURYSTA, but even still in many patients, SLT is really my first-line treatment for glaucoma in patients that I diagnose with glaucoma or that are referred to me diagnosed elsewhere, not initiated on treatment in order for me to do primary SLT. So this is going to be a really interesting study. So let's talk about how DURYSTA is changing my practice. Again, SLT is still my first-line treatment, but many glaucoma patients are on too many drops. And if you don't think so, ask them. DURYSTA is a reasonable second-line treatment, but it is contraindicated if patients aphakic, has chronic uveitis, active hepatic infection, or poor endothelium. Certainly anyone that's had a corneal transplant, I wouldn't implant DURYSTA. But even if only one injection is performed, many patients, I said earlier in a previous slide, over 60% of patients on glaucoma medications have ocular surface disease. Well, many patients need a holiday from drops so you can focus on healing their corneas. So one of the techniques I do is I will stop all of the glaucoma medications that a patient is on after I inject the DURYSTA. And then that's an opportunity to consider doing either punctal plugs or having them just on cyclosporin and tears, maybe a mild steroid for a very short period of time, or this is where an amniotic membrane would be helpful to really, you allow that amniotic membrane to do its job while the cornea is not being assaulted by the preservatives in the glaucoma drops. So many patients, if you ask them if they have severe dry eye, hey, if we can get you off these drops for a short period of time, maybe even up to 6 months to a year, and let your corneas heal, would you be interested in doing that? You'd be amazed how many patients would be falling over themselves, begging you. They're like, yes, I just need some relief. So, DURYSTA is also a good option if patients don't want to be on drops, you've done SLT already, and it's starting to wear off a little early. Like, I usually won't repeat SLT if it wears off before 9 to 12 months. So you could consider DURYSTA for sort of breakthrough IOP elevations between yearly sessions of SLT or every other year of SLT, depending on how they respond, in order to strategize keeping patients off medications. Now, there is a facility fee if it's done in an ASC or a hospital. But what I do is I do it in the office. And I have dedicated weekly DURYSTA injection clinics. You could also intersperse them with your regularly scheduled patients. But I like to do lasers and DURYSTA injections all in the same afternoon, and I bounce back and forth between the laser room and the room in which I'm doing the DURYSTA. The global period is 10 days. Certainly for the first several months after implanting DURYSTA, I was seeing them at a week to see how they were doing. But now that they've essentially all had minimal, really totally innocuous findings at week 1, I like to see them at month 1 because I really want to see them when it's truly efficacious and see that they had a response to the DURYSTA itself. There are some surgeons that are pushing it to 6 months, but I do believe it's good to see them at a month, and then, consider seeing them 4 or 5 months after that would be reasonable, and gauge it from there. So that's DURYSTA. One of the future possibilities or opportunities to help our patients with glaucoma is going to be the IDOSE. So the IDOSE is is made by Glaukos. I was in both the phase 2 and phase 3 IDOSE clinical trials, so I can't reveal too much in the way of results, because the results certainly for phase 3 haven't been published yet, but there have been some phase 2 things that have been released. Now, the IDOSE, what it is it's basically a titanium implant that resides in the anterior chamber. It's anchored in the scleral tissue just behind the trabecular meshwork. And here you can see where it's positioned in the eye. This is a photograph where you can see it. I typically like to implant it superiorly so that the eyelid can mostly cover it. If the patient's really looking for it, that they can see it. But it is parallel with the iris. It does not touch the cornea. It does not move. Here's a video of me implanting the IDOSE in a clinical trial. And essentially, you make a 1.8 millimeter incision or so. I would make it inferiorly, pointing toward 12 o'clock. I use just lidocaine in the anterior chamber, and then put viscoelastic in the anterior chamber and on the corneal surface. And essentially, it has this anchor on it, and you simply depress it into the trabecular meshwork, into the wall of the eye through trabecular meshwork, in order to secure it, essentially. And we do kind of a touch test on both sides just to make sure it's secure. So here you can see I'm just going into the angle and pulling the slider back to release it, and then just checking stability from side to side. And then you just flush the BSS, the viscoelastic from the anterior chamber. You definitely want to use a cohesive viscoelastic to prevent pressure spikes, and I've never seen one in many implants of this device in the clinical trial. So I did, a number of years ago when I was still at the university, I did report the interim results of the phase 2 data of interest. The patients had no endothelial cell loss with the DURYSTA, and it worked. The people in the control group was timolol, so it certainly beat timolol, but it also had significant endurance. And I think what we're going to be seeing with the IDOSE is, even after several years of follow-up, it's going to still be working, not only because of, as we've discussed before with DURYSTA, with the permanent effects that these implants have on the endoscleral outflow, but in the case of IDOSE, with the release of medication simply because of the larger reservoir, and then the release of medication over an extended period of time. And then once the IDOSE is empty, the goal is then to just what you do. And we actually had an exchange study where really when the IDOSE, after the phase 2 study was over, the patients that were randomized to the IDOSE, simply we pulled it out and put a new one in. Very safe, and really a wonderful concept. I even foresee these probably being done in the office in a minor room under sterile technique. So how would the IDOSE change the glaucoma landscape? Well, the vast majority of glaucoma patients are controlled on one prostaglandin. If the IDOSE lasts 3 to 5 years before needing to be replaced with a new one, you can just imagine the implications of that. And again, the improved side effect profile. All the side effects from topical medicine, no more. We won't have any more periorbital fat atrophy from topical prostaglandins or dark circles under the eyes or long eyelashes. You can still get a change in the iris color in eyes that are sort of hazel. That's a risk, and although it should still be fairly rare. And there is still a possibility in a limited number of patients to have some mild inflammation, and we see that with topical prostaglandins too, however. Poor compliance is the main cause of glaucoma progression, and we really will see a profound improvement in visual field stability and a decrease in overall blindness around the world. So here's the other thing. This would be a new first-line treatment for virgin eyes with high IOP. You can always do SLT after. You don't necessarily, you could, because of the long-lasting effect of the IDOSE, I think we'll definitely see an increase in first-line IDOSE. And, again, we didn't see any corneal endothelia issues. Most of the patients I've done have been in phakic. But, the IDOSE may also fulfill the biggest dream of more eye drop-free patients by doing it maybe in combination with an iStent or a hydrus or, you name the canal procedure, where, it would be implanted along with it. So you would do your cataract surgery, you do your MIGS procedure, and then implant an IDOSE in order to maximize the opportunity, because you're already in the OR, to make sure the patient is medication free. And again, this could be done in the office with a microscope under sterile condition, but I definitely foresee a lot of combined phaco-MIGS IDOSE in our future. And again, what if a patient still needs an eye drops? Well, this is our transition. So some people just need to be on medications. They just need more than one medication to get control. We saw with DURYSTA and IDOSE that you could stop 2, 3, 4 glaucoma medications and successfully get a fair number of patients off them completely for a long time with the sustained release model. But some folks, you need to add something back on. And some people, especially the folks that were on 3, 4 meds, might need to be on more than one rescue medication after sustained release or after SLT. A lot of times, we also have patients that just kind of refuse to let you do any intervention because they have too much anxiety about laser or an injection. They hear these words and they get very concerned. Or they're patients that just, you've done everything and they really need surgery and they're refusing surgery. So this is where fixed combination glaucoma medicines that are compounded come into play. Because some people still need a lower pressure. We know compliance goes down with each additional bottle of eye drop. I have a saying, this is important, friends don't let friends use 3 bottles of glaucoma eye drops. And now we have a solution that actually helps allow a patient to have 3, 4 medications without the requisite bottles. So there are several companies that do this. I use the OSRX pharmacy because I found their customer service to be excellent and just had better accessibility in my area. But here are 3 formulations from them. Here's the Timlat, which is not available in the U.S. in a branded form because the FDA required any fixed combination to have a pressure of the patients to have pressure of 2 millimeters of mercury lower when in fixed combination than when given separately, which is interesting because a lot of times we're doing this for improved compliance, not necessarily to have improved efficacy. So I think the FDA perhaps doesn't understand how these are most frequently used, but there is a Timlat because a lot of patients are on Timolol and latanoprost separately, and I pretty much switch them all over to Timlat. And I have them take it once in the morning because Timolol works better in the morning, and the latanoprost is less relevant when they take it. And then they make a Tim-Brim-Dor, Timolol, brimonidine, and dorzolamide, and a Tim-Brim-Dor lat with those three with latanoprost as well. And the Tim-Brim-Dor lat, often I prescribe as an AM/PM. So they take the Tim-Brim-Dor in the morning, the Tim-Brim-Dor lat at night, and that allows me to not have a patient on a BID dosing of a prostaglandin, which can increase the risk of inflammation and side effects when on BID dosing. So here are some case examples of how I use the compounded glaucoma drops to get you thinking. So case 1 is a 65-year-old gentleman with a pressure of 19 after repeat SLT, already on dorzolamide, timolol, and latanoprost. Target pressure is mid-teens, and the patient just tells you, "Doc, sometimes I forget to take my second dose of dorzolamide timolol." The patient's had brimonidine worked in the past, but was switched due to formulary changes. So here's a patient that I basically switched their fixed combination of dorzolamide timolol twice a day and latanoprost at night to that AM/PM formulation that I talked about, and the patient's pressure went down to 15. Case 2, a 78-year-old woman controlled on timolol, BID, and latanoprost QHS, mild dementia, and she describes falling asleep before taking her latanoprost 50% of the time. She falls asleep before taking it. It's not compliance, and she's going to get worse. So what I did was I switched her to the Timlat, and I told her to take it in the morning after she gets out of bed. She doesn't forget to take it anymore. Case 3 is a 55-year-old man, IOP controlled on fixed combination dorzolamide timolol, brimonidine, and latanoprost. And, I asked him, "Mr. Jones, how much are you paying for all those drops?" And I ask this all the time. If anyone is on more than one glaucoma medicine, I say, "How much are you paying for all this? Cash, how much are you paying for all this after insurance and everything?" He said he was paying almost $250 for a 3-month supply. So I switched him because he was basically on the same thing anyway, but I gave him the AM/PM, and his pressures were the same basically, but he was so excited because I set him free from paying all that money that he came and bought my office coffee and donuts at the next visit. Case 4, 60-year-old woman on fixed combination dorzolamide timolol twice a day, moderate glaucoma, pressure of 18 after SLT. You want better control. This is a patient that refused a prostaglandin analog because of the unwanted cosmetic side effects. So this is someone who I just was able to switch from one BID drop to another by switching her from fixed combination dorzolamide timolol to the Tim-Brim-Dor. So here's the real cost, though, of not switching your patients to these compounded glaucoma drops. And this is really exciting. It's not just about the cost to the patient. This is really for your office. Think about it. If you no longer have to do prior authorizations, you don't have to change things around and answer a bunch of phone calls when there are formulary changes. And you don't have to have your staff waste their time on the phone with pharmacies and insurance companies. Now, I own my practice. This is a big deal. This is money I'm spending where they could be spending on staffing that they could be doing something else. But even if you work for a company that runs your practice or you're at the university, it's actual work, extra work, for which you get no compensation if you're an employed physician for messing with all this stuff. And it's a colossal hassle to be having to answer all these emails and phone calls from your staff saying, "Well, what can I switch this patient to?" Because of a formulary change. And there's really no paperwork and no frustration. So the cost to the patient, the cost to your practice, the opportunity cost of your time, but then, of course, the most important thing is improved compliance and less blindness in the world because of you being creative and thoughtful and trying something different. So in summary, sustained-release glaucoma medications will continue to change the glaucoma landscape in the right patients. And once we get longer acting treatments, interventional glaucoma will expand even further. Fixed combination glaucoma drops have been available for a long time, but our commercial options have been very limited. The big pharma options have been limited. And with compounded drops for glaucoma, we will see improved compliance, better efficacy, and lower costs for the patient and the whole healthcare system. Thank you very much for your time. It's been a pleasure visiting with you today to talk about sustained release, glaucoma medications, and compounded glaucoma eye drops. Thank you.